followers of Neuro Takeaway, welcome back to the channel. Today we are going to see the evolution of the patient that we presented in the last video. Just to remind you, he was a toddler with an empyema and several abscesses in his right cerebral hemisphere that on the evolution, on the MRI studies, we had some confusing and contradictory findings. For example, there was an increase in the edema and the mass effect of the lesions of the abscesses, and there was a reduction of the restriction on diffusion, as well as a lowering of the gadolinium enhancement and a change from an annular pattern to a nodular pattern. So now I show you the further studies. As you can see, there was a very good evolution. Here we have a diminishing of the edema and the mass effect, and finally the resolution of the abscesses. The same happened on diffusion, on ADC maps, and there was now, finally, there was no gadolinium enhancement. So let's talk something about this structure, the abscesses. To start, when a bacteria invades the brain from the blood or from the paranasal sinuses, they have several antigens in their walls. For example, Staph aureus has proteoglycans that can trigger, that can stimulate the toll-like receptors that are located in the membranes of the astrocytes and the microglia. And as you know, these toll-like receptors can trigger the inflammasome production. By this production, there is a release of the expression of some transcriptional factors as NF-κ-beta, which can produce some cytokines as TNF-alpha and interleukin beta that can produce more permeability of the blood-brain barrier with adhesion and transmigration of inflammatory cells as neutrophils, lymphocytes, and the macrophages. But this structure is very complex. It has several layers. In the center, we have a necrotic core with debris. Then we have a layer of granulation tissue, then the fibrous rim, and surrounding all these, we have gliosis and edema. There are several stages to reach the final mature abscess. The early cerebritis phase, which takes place in the first 3 or 4 days, consists of hyperemia, edema, neutrophils and monocytes infiltration, isolated foci of necrosis, and the presence of sometimes of petechial microbleeds, which are more frequent, by the way, in children. Then we have the late cerebritis stage, which takes place during the first 5, from the 5th to the 9th days, where we have progressive and coalescent foci of necrosis surrounded by a thin layer of granulation tissue, which consists especially of macrophages and fibroblasts. And we have now some reticulin fibers, and there is a peak of edema in this phase. Then we have the early capsule stage that takes place from the 10th to the 14th days, with proliferation of the granulation tissue that surrounds the liquefactive necrotic core. And there is a thin capsule with collagen now, and there is less edema. And finally, we have the late capsule stage after the 15th day, with the 5 layers of the mature abscess. We have a central necrotic core with debris and pyocytes. then the macrophages fibroblast granulation tissue layer, then the thick capsule with collagen. Surrounding this, there is, and close to this, there is a layer with neovascularization and perivascular inflammatory cells, which is the layer that enhances with gadolinium. And at the periphery of this layer, there is the edema and reactive leosis. And it's very important to know that this edema mass effect is less evident in the mature abscess than in the previous stages. And here you can see how we see these phases on MRI. The early cerebritis consists of a very heterogeneous lesion, especially hyperintense, with hyperintense signal on T2 and hypointense on T1, with some heterogeneous pattern of enhancement, a lot of mass effect. As we said, it consists mainly of edema. Here we have some hypointense linear areas that may be due to hemorrhage, which is more frequent in children, as we said. Then we have the late cerebritis phase. On T2, you can see in this temporal lobe abscess the presence of more focal hyperintense lesion with some heterogeneous pattern of restriction and diffusion, and a very, very thin linear pattern of enhancement. Then we have the early capsule stage with more consist restriction and diffusion in the center of the lesion, and a very thin layer of peripheral enhancement, which tends to be thinner at the ventricular border of the abscesses, and that's why they tend to rupture to the ventricles. Some of these lesions may have umbilications and daughter's abscesses. And finally, the mature abscess. The typical characteristics of this stage is the presence of this hypointense ring on T2, which is hyperintense on T1 without GAD, and it represents the presence of free radicals secondary to the activity of the macrophages. Here we have, again, the mature abscess phase with the typical linear peripheral enhancement with the umbilications and the very strong restriction, which is almost always present. There are some exceptions, but in general, we have this very easy way to diagnose an abscess. Now we know some other features that are present, for example, in this new sequence SWI, as the double ring sign. The double ring sign consists of two rings. The peripheral ring is hypointense and is due to the presence of free radicals secondary to the macrophage activity. And in the inner ring is hyperintense and represents granulation tissue. It's very important, this sign, to differentiate an abscess from a tumor, especially from necrotic glioblastoma. Let's say something about the changes of abscesses with treatment. There are some controversies in this point, but in general, there is a consensus to follow up these lesions every 2 weeks with an MRI, with GAD, and with diffusion. The parameters of good outcome are the decrease of the volume of the abscesses at a rate of about 10 to 15% per week, and the resolution of 3 characteristics: the GAD enhancement with a change from a nanular to a nodular, as we saw in our patient, the resolution of the hypointense ring on T2, and the resolution of the restriction. There is a tend to a facilitation of the inner core of the lesion. And it's important to remember that there may be a residual contrast enhancement present for up to 6 to 9 months, and that doesn't mean that this is a bad evolution. But speaking about our case, what about the edema? What was that increase of the edema that was so confusing? Well, as far as I know, there is no reports about this pattern on pyogenic abscesses, but you can see that in tuberculous granulomas and abscesses, there is a very large literature. We ourselves published a case. This case was from our hospital with a tuberculous granuloma that worsened with treatment. There is an increase of the size of the lesion with more edema and mass effect, and then eventually they did very well with the same treatment. So this, let's say, paradoxical reaction that has to do evidently with a particular host reaction to this treatment of an infection can maybe present, even though it's not frequent in pyogenic abscesses. So with this video, I wanted to stress the importance of taking into consideration the traditional parameters that we have to assess the evolution of brain abscess under treatment. I would like to thank you and congratulate all the participants in this first Better or Worse quiz. And finally, I would like to invite you to the next video because we have a very special guest and I'm sure you will enjoy her a lot. Bye-bye.